Hello everyone, welcome to my YouTube channel. Today we are going to talk about management of segmental bone defects. Before we start, there is a disclaimer. This video is for informative purposes only. I am advising you to refer to the main textbook or sources that is used in each teaching center respectively. Thank you. Now let's begin. Before we start, I will introduce you to biologic concept of bone graft and its function. It has 4 biologic concepts. 1 is osteogenesis, 2 osteoinduction, 3 osteoconduction, and 4 structural support. For osteogenesis, it provides stem cells with osteogenic potential which directly lays down new bone. 2. Osteoinduction, the induced differentiation of stem cells into osteogenic cells. It needs BMP, bone morphologic protein for stimulation. 3. Osteoconduction, provide scaffolding upon which new bone can form or provides matrix for bone growth, or a framework we call it, for structural support. For management of segmental bone defects, optimal patient characteristics are reliable and well-informed patient, stable soft tissue envelope, adequate nutritional status, and absence of tobacco use and infection. Critical segmental defect means that bone void that will not fill without intervention, whereby there is a circumferential loss more than 50% and or length of more than 2 cm. Management of segmental bone defects will include 1. Autograft, 2. Allograft, 3. DBM, Dimineralized Bone Matrix, 4. Masquelet technique, 5. Distraction osteogenesis, 6. Vascularized fibula graft. For autograft, it can be used in defects less than 5 cm in size. If defects is more than 5 cm, bone graft will be resolved due to revascularization and clearance of necrotic graft tissue. Common site for autograft is iliac crest. Iliac crest is an ideal source of bone graft because it is relatively subcutaneous, it has ample cancellous bone, it has cortical bone with varying thickness, removal of bone carries minimal risk, usually no significant residual disability. There's a large cancellous and corticocancellous graft may be obtained from the anterior superior iliac crest and posterior iliac crest. So autograft advantage is that A. There is no disease transmission, same patient only from one body site to another. B. No immunogenic reaction. C. Osteoconductive, minimal osteogenic and osteoinductive factors. D. Low cost involved. Disadvantage of autograft is that it has a donor site morbidity, whereby it can present with persistent pain or infection or limited volume compared to allograft. 2. Allograft. Allograft is taken from the same species but different person or individual, usually from a cadaveric donor. Process of sterilization of allograft bone with chemical or irradiation will reduce the viability and strength of the graft. Irradiation will kill bacteria and viruses. Allograft cancellous bone acts as an osteoconductive material and incorporated into host bone by creeping substitution. Cortical strut graft has structural properties. It is very useful in reconstruction of segmental defects. Advantages of allograft: no donor site morbidity, limitless volume. Disadvantage: limited graft incorporation or remodeling, potential disease transmission, minimal or no osteoconductive or osteogenic properties, is very costly. Types of allograft can be divided into fresh frozen, and freeze-dried croutons. For fresh allograft, it is the higher risk of disease transmission and immunogenicity. BMP is preserved and therefore osteoinductive. For fresh frozen, less immunogenicity than fresh allograft. BMP is preserved, therefore is also osteoinductive. For freeze-dried croutons, is the least immunogenic, least structural integrity. BMP is also depleted. It is purely osteoconductive, but it has lower risk of viral transmission. 3. For DBM, Dimineralized Bone Matrix, DBM alone is ineffective in management of non-union and segmental defects. DBM is prepared through the use of a hydrochloric acid solution to reduce the mineral content of crushed allograft bone while preserving the osteoinductive organic scaffold and osteoinductive growth factors. 4. Induced membrane technique, Masquelet technique. It can be used to fill in defects between 5 cm to 25 cm. It has 3 main benefits. 1. It induces membrane that create a separate compartment, limiting autograft resorption. 2. PMMA, polymethyl methacrylate spacer, maintains the defect space for delayed bone graft. 3. Induced membrane is rich in growth factors that improve graft consolidation. Masquelet technique involves 2 stages. The first stage, whereby segmental defect is radically debrided and PMMA cement spacer is placed. Bone defect is stabilized with external fixator or internal fixation. Second stage, after 6 to 8 weeks, membrane is carefully incised and preserved while the PMMA spacer is removed. The defect is filled with autologous bone graft. Then, stabilization by intramedullary nail or plate. Early weight bearing depends on fixation stability. It is good because early weight bearing helps in stimulate bone healing. The advantage of Masquelet technique include internal or external fixator can be used. Reconstruction time is independent of the size of the defect. Disadvantage is it is a 2-stage technique. Ratio of allograft to autograft should be less than 3:1 ratio. 5. Distraction osteogenesis. It involves transporting a segment of bone in a controlled manner using an external fixator or an intramedullary device. Better if pre-operative planning of frame with wires and half pin are done prior. A metaphyseal corticotomy performed with a drill and osteotome to minimize the heat production and thermal damage. Following latency period, transport phase begins and continue at a rate 1 mm per day. Once transport segment reach the far end of the defect, the segment is compressed for several weeks until fracture callus form. If consolidation of the regenerated bone is slow or incomplete, secondary autologous bone grafting is performed at the docking site in conjunction with compression. The consolidation phase lasts 2 times as long as the transport phase. The regenerated bone is formed from the periosteal and endosteal surfaces of the transport segment. The advantage and disadvantage of Masquelet technique. Advantage is a reliable technique, minimal risk of further injury to the soft tissue, no donor site morbidity, no restriction on defect length. It can reduce the reconstructive time with multiple osteotomies, and transport segment. The disadvantage is a long reconstructive period, risk of pin tract infection, risk of fracture of regenerated bone, risk of stiffness. Additional note: how to prevent a pin tract infection? Proper pin or wire insertion by correct placement that adhere to safe zone by avoiding ligaments and tendons. Avoid heat necrosis during pin or wire insertion. Extending the skin insertion to relieve the soft tissue tension to prevent skin necrosis. And lastly, the pin or wire insertion site should be cleaned by dressing with saline or disinfected solution or alcohol. And finally, 6. Vascularized fibula graft. It is effective in managing larger defect more than 6 cm. Fibula can be resected as close as 4 cm to the fibula head and up to 6 cm proximal to the ankle joint. The advantage of the vascular fibula graft is it is effective in cases where there is poor vascularity at the recipient site, such as in infection and followed by radiotherapy or following radiotherapy. In vascularized graft, most cells remain alive, preserve the bone remodeling, and bone able to integrate and even hypertrophy. It often shows similar healing characteristics to those simple fracture. The disadvantage of vascularized fibula graft is donor site morbidity, restricted weight bearing, because to prevent fracture during fibular hypertrophy. So, okay, that's all for today. See you next time. Bye.